good sense to decide which are the ones that need to be. And I think it makes sense because if you're going through a whole series of cases, then asking the question on a particular case right at the end of the whole lecture may not be have the desired effect. All right. So without much ado, let me share my my screen. All right. Can you see the PowerPoint? I just have to make it full screen. Okay. I've termed this thing Curiosa et Exotica for the simple reason that these cells that we call accessory cells are not very much. We don't pay much attention to them. And when they do turn up on your surgical pathology plate, so to speak, we are often unfamiliar with these lesions, not least because they turn up in many different situations at many different sites, and they also seem to have many different faces. And that's why I've called this the many faces of accessory cell proliferations. Right? I know that we've got 5 students here, and they knew that they were going to be in this particular lecture or going to have to answer questions, etc. So let me start by asking, before I go to the next slide, I'll ask each of them. Maybe you can start, Gaurik. What do you think is an accessory cell? Gaurik, can you hear me? Hello?
I think it's mute. Can you unmute him?
Dr. Gaurik, please unmute.
If he's not able to hear or talk, Divya,
yes.
Oh, Gaurik has
Sorry to interrupt. Yes,
All right, Gaurik.
Yeah. Ma'am, when we talk about accessory cells, when we basically talk about a lymph node, the main cells are the cells which constitute the cortex or the medulla of the lymph node. When we talk about the accessory cells, these are basically the cells, additional cells, which may be present at the extranodal sites as well. For example, the blood vessels, as well as in the lymph nodes. For example, the dendritic cells, the histiocytes, etc. The Langerhans cells. So these cells, for example, dendritic cells, they can be a part of the germinal center of the cortex.
You think that these are cells that are present either in a lymph node or at extranodal sites, and they're not lymphocytes. I think that's what
yes, precisely.
Yeah, you believe. Okay, but you haven't said, and maybe I'll ask Divya that question. Why would we call them accessory cells? Divya, do you understand what is the meaning of the word accessory?
Essential.
Accessory is essential. No, I don't think that accessory is essential. So let me ask, and then I'll come back to you, Divya, to ask, because if you don't understand the word accessory, then it's a little sort of difficult to understand what cells we might wish to be talking about. Okay, Swati, what do you think is the meaning of the word accessory?
Ma'am, not primary, but then second line of defense or something like that.
Second line of defense. Okay, Angela?
It is related to the lineage.
It's an English word, accessory. Do you know? And as a woman, I'm not asking Gaurik because he's a man. Not that men do not have accessories, but women have a lot of accessories. No, what when we dress and so on. So, what are these accessories that we talk about? As I think Swati said, it's not the main thing, but it is.
Like we have the lymphoid tissues, and then there are cells which present the antigens to those lymphoid tissues. So they are acting like a.
So you're talking about it in terms of lymphoid tissue, okay? But I was just asking in general, and maybe Lydia can take the question. Why am I calling these accessory cells? What is an accessory? And I said that ladies use all kinds of accessories. Okay, to do what? Like for instance, the tie is an accessory that a lot of men use. All right, ladies use a lot of jewelry. Not that men never used to use or men don't use today. I find that men are using a lot of jewelry. All right, that I wouldn't have seen in when I was growing up with my brothers or cousins or my father. Today, men have got all kinds of jewelry, and sometimes I envy the kind of jewelry that they have, and I wish that I could use them, except that they're too large for my wrists. So, what is the meaning of the word accessory? Yeah, Lydia, what do you think that word means?
Persons which perform a function apart from the principal function.
Yes, that's you're talking. Yes, you're right. But you know what the word accessory means? Accessory means something that is not the main thing, like you said, but enhances. Okay, so when we use an accessory. Okay, it helps or enhances whatever the function that is going on at that time. Now think, and when you think about that particular word, an accessory, it's also used in law and in the police use it. He was an accessory to the murder, or he was an accessory to a theft. Okay, and it's not just a minor thing. It is like somebody without which, or somebody or something without which, the overall function would not be adequately performed. Okay, so that's why we women use so many accessories. Yeah, men use it so that we enhance whatever it is that we are trying to do. And when dressing and going out, etc., is all very much part of the function of our social lives. Do you agree, Gaurik? Yes.
Absolutely.
So now, if you ask what are accessory cells, and you've all given me a fairly good idea that you understand basically what an accessory cell is, and they're cells that assist. Okay, so they have an important function. It's not just that they happen to be there, in the lymph node, or they happen to be in extranodal sites. It's nothing about just being or happening to be. They have a very important role in an adaptive immune response. What you were talking about, how various tissues respond to in an immune kind of way. Some may also play a role in the innate immune response. And I honestly don't have the time now to tell you guys the difference between an innate immune response and an adaptive immune response. All of you are the 5 students are second year students, and this is the time I think you should be being familiar with immunology, and immunology is such a fascinating subject if you don't go into immunology as if it is, oh, what a boring thing that we have to learn. And that's why a little while ago I told people, those who are going to come as students for the next talk or slide seminar on the spleen, should familiarize themselves with the evolution, in other words, of the spleen. How did the spleen come to be, and how its function has changed during the course of evolution? What does it do with us, and what sort of role does it play in the immune response? So I'm glad that we are doing these sort of things, the accessory cells today, the spleen next Tuesday. Now, what Gaurik said is absolutely right. They are not lymphocytes or NK cells. Okay, so they are completely apart from these, although they may share a certain lineage with the lymphocytes or NK cells, right at the stem cell level in the in the bone marrow or other sites, and some have no connection with the bone marrow at all. And usually we refer to these accessory cells as histiocytes and dendritic cells. Now, if you ask me, and I've been in pathology, oh God, for years and years and years, more years than some of you have actually even lived on this earth, and you ask me to define a histiocyte, I'm sorry, but I would not be able to do that, because the word histiocyte, or for that matter macrophage, means so many different things to so many different people. And I know that I'm talking about accessory cells, and maybe I should be trying to define histiocytes, but I'm not going to do that. I think we just have to accept that there are many definitions, and that we accept that some histiocytes at some places will be called macrophages, macrophages may be called histiocytes. I know that the textbooks talk about tissue-based lesions and what's in the blood are known as monocytes, etc., etc. But I think we'll leave that semantic discussion for another day or for another time. But I think, I don't know, it was Lydia who mentioned that many of these are antigen-presenting cells. Okay, and that again, go back to immunology, and you will know what an antigen-presenting cell actually is. Okay, now that we've established what these are, when you think about accessory cells, all right, you see a dividing line here. There is a black line that I have drawn. Now that black line divides these accessory cells into two major groups, and you can see that there. One comes from a myeloid stem cell, and the myeloid stem cell is CD34 positive. The other one is a mesenchymal stem cell, and I don't think we have any particular marker to mark that mesenchymal stem cell. But I mean, ultimately, we all come from one fertilized egg, which we call the zygote. But you know that there is a differentiation that is taking place, and we have systems in our organization of the functions of the body, and really there is no connection, okay, of the mesenchymal stem cell with the myeloid stem cell. Okay, so let me just go through these accessory cells, and please feel free to take screenshots or to ask if you don't understand anything about what's going on, because you probably would need to wrap your heads around this, because we don't think of this in an everyday sort of way, unless you happen to be a hematologist or somebody who's doing flow cytometry, or maybe somebody like me who has an interest in lymphomas and hematolymphoid lesions. So if you look at this myeloid stem cell, there will be at the precursor stage three different groups, or three different sub-stem cells, if you want to call them that. One is the classic one that ultimately ends up being a monocyte that is, in the blood, or when it is in the tissues and it is phagocytic, we call it a macrophage. You might wish to call it a histiocyte, as I told you, that this is something that I'm not going to elaborate or quarrel with, okay? Then you have, and if you look carefully, if you take just this one marker, CD1A, okay, you will find that a monocyte is CD1A negative. It is CD11C positive. Now, these we know because of differentiation markers that are used in flow cytometry, and some of them we actually use in histopathology using immunohistochemistry, and you can see examples as we go along. And the important marker there is CD14. Okay, if you notice that CD14 is absent in the other precursors of this particular group of accessory cells, the myeloid stem cell family. Then of course you might have CD68, which is positive. You go to the next precursor cell, and you'll find that for the first time now there is CD1A. But there is no CD14. And although there is no CD14, there is CD11C plus. So they're sharing some markers with each other, and this is useful when flow is being done, or even when we use our immunohistochemistry on tissues. All right, then we come to the third cell, which is CD1A negative, CD14 negative, CD11C negative, but which expresses CD123. Okay, so this is at the precursor level. When these differentiate, you'll find that there is a group, and I've shown this by showing you that they have processes to the cytoplasm, and those processes we call dendritic cells. Okay, so there is a group of cells that end up having processes to the cytoplasm, and then there is, in this first group on the left-hand side, the monocyte group. It doesn't have processes. Well, I suppose a macrophage does have processes when it is trying to phagocytize something, and then little pseudopods come out. But they, by themselves, they do not, as mature cells, actually have cell processes. Okay, so they will at some stage change their shape and throw out pseudopods if they have to engulf something into the cytoplasm. But they are basically just spherical-looking cells, may have an irregular shape, but they do not have dendritic processes. Okay, but these are other cells which have dendritic processes, and we'll see as we go along that you have a group of from the monocyte lineage, you have something called the interstitial dendritic cell. Okay, that is again CD1A negative because it comes from a CD1A negative precursor. There's factor 13A positive and CD68 positive. So it is one of these dendritic tissue, for want of a better word, histiocyte, because histiocytes express CD68, as do these macrophages that are present in the tissue. They also express CD163. All right. Then when you come to the other precursor, this is the famous Langerhans dendritic cell, where it is CD1A positive. We know that it is S100 protein positive, and there is Langerin. Now CD207 is another. It's a cluster designation number for Langerin. Okay, and Langerhans described these cells in the skin and also in the lymphoid tissues, and this has been given his name, and therefore we have Langerin. Now these cells, then you see that there are arrows that go in every direction, this way, that way, etc. Because these may differentiate into what are absolutely full-blown Langerhans cells, which you see in the tissue. You are able to see their morphology, and they have a similar immunophenotype to this Langerhans cell, which is which hasn't differentiated into what is called a veil cell. Now, as far as I'm concerned, I cannot identify a veil cell in histology. Okay, it is something that still sort of is present in the textbooks, but it has an immunophenotype exactly like that of a Langerhans cell. Okay, on the other hand, you have an interdigitating dendritic cell which expresses S100 protein, is negative for Langerin, and is negative for CD1A. It just has S100 protein, and we'll talk a little bit about it, and we'll see what sort of lesions it gives rise to. Okay, but you can have, because there is this little bit of merry-go-round between the Langerhans dendritic cell, the veil cell, the interdigitating dendritic cell. There may be cells which will not follow this lineage, these markers to an absolute T, and therefore you will have in this group sometimes cells that are absolutely indeterminate. There will be a little CD1A, there may be some S100 protein, but there won't be langurin. There may be just S100 protein, and a few cells here and there might express CD1A. But the full-blown phenotype of Langerhans cell, the Langerhans cell will not be available when we do our immunohistochemistry or flow, for that matter. And then you have the plasmacytoid dendritic cell, okay, which is the dendritic cell that is famous for being seen in quite large numbers in viral infections. And Kikuchi-Fujimoto disease is one of those in which you get a number of fully activated plasmacytoid dendritic cells when the dendrites are, we don't see it well in histopathology because they all shrink after this has been undergoing processing. All right, now that we've talked about the accessory cells that come from the myeloid lineage, let's just go quickly to the mesenchymal stem cell. We do not know what the precursors are because really I don't think we are able to identify them in any particular site because the mesenchymal cell is a very plastic cell, but there are two interesting forms. One is the follicular dendritic cell, which is seen in the follicles of the lymph node, and without the follicular dendritic cell, a follicle could not form. Okay, so all these lymphocytes, B lymphocytes, and the follicular helper T cells are all held together in these almost like embraced by all these tentacles, meaning all the dendritic processes of the follicular dendritic cell, which has no relationship to any lymphoid lineage. Okay, so it's only comes from a mesenchymal stem cell, which of course we're not able to identify. And then there is what is called the fibroblastic reticulum cell, which funnily enough expresses keratins and is usually shows you some muscle-specific actin in it. Follicular dendritic cells I've shown you here. The three classic markers are CD21, CD23, CD35, and portoplanin, which is D240. All right. Now, you saw all that. Now let us see what kind of lesions, particularly tumors, arise from the different precursors and the fully differentiated cells of any of these accessory cell lineages. So you know that the monocyte, if it is a precursor thing, you would call this AML, and it's either monocytic or myelomonocytic. Yeah. Once you come to the macrophage stage, where there is phagocytosis that is occurring, you have 4 different kinds which are very easy to identify. That is Erdheim-Chester disease. There is Rosai-Dorfman Destome now, because it was once upon a time just called Rosai-Dorfman disease, but now we know that there was a Parisian whose name was Destome, and so now to give him his due, because he had also described this lesion, I think, much before Rosai and Dorfman did this, and I hope you know that Rosai and Dorfman are 2 different people. So it's now known as Rosai-Dorfman Destome disease. Then there is juvenile xanthogranuloma. Then there is a malignant histiocytoma, malignant histiocytosis, which is the malignant counterpart of this disease. And then you have Langerhans cell histiocytosis. You have an interdigitating cell tumor, which is S100 protein positive. And then here, as I told you, between this, and this, you can have all kinds of different variations. Sometimes one of these will express CD68, which they should not be doing. And then we just call that an indeterminate dendritic cell tumor. Now on this side, you have what is essentially now called a leukemia, and that is plasmacytoid dendritic cell tumor, which is blastic plasmacytoid dendritic cell neoplasm, which is today believed to be a leukemia because anyway it belongs in the precursor group, and just like you have an AML with monocytic differentiation, this is a dendritic cell differentiation. And I'll just show you an example, but essentially it doesn't come very often on a surgical pathology palette, but yes, it does involve the skin quite often, and that's where we need to recognize it. Here, this is the follicular dendritic cell tumor, and you have the fibroblastic reticulum cell tumor. It's got a little different name now, but it's a little too long to put it over here, and that's why I just summarized it as that. Okay. So now let's get down to the classification of these tumors. There have been umpteen classifications over the years, not least because I don't think that people are able or were able in any major way to determine what was a histiocyte, what was a macrophage, what is a dendritic cell, etc. And many of these things were arbitrary. But I think as far as the WHO was concerned, in the last edition, that's the 4th edition of the WHO in 2016, they took a view that these should be called dendritic cell and histiocytic neoplasms, as it is written over here. But it is not exactly what is now in WHO 2023. And just look at the left side of what I'm saying, okay? Now what is being called histiocytic and dendritic cell neoplasms now fall into these myeloid neoplasms because of their myeloid stem cell derivation. That is what we saw on the left-hand side of the two cartoons that I just showed you. Now, what then, what happens then to those, and we've been calling them dendritic cell tumors now for such a long time, the follicular dendritic cell tumor and the fibroblastic dendritic cell tumor. And here you see that those of mesenchymal derivation are now classified as stromal-derived neoplasms of lymphoid tissue, and they do not appear in the group of myeloid cell tumors. Yes, they will appear in the lymphoid tumors, because you know that this 5th edition as well as the 4th edition had divided things into basically those classification of lymphoid neoplasms and classification of those neoplasms that had something to do with the bone marrow. Okay, so if you want to know what the WHO is now including under dendritic cell and histiocytic neoplasms, it is one which is very, very new, and it's called a mature plasmacytoid dendritic cell proliferation associated with a myeloid neoplasm. Now this they're not saying that it is benign, but at the same time, they're not saying that it is malignant. There is a myeloid neoplasm, and you get perhaps an overgrowth or a proliferation of mature plasmacytoid dendritic cells. They are not blastic in any shape or form, not even from their morphology. Okay? And then, of course, the blastic plasmacytoid dendritic cell neoplasm, which I've already talked to you about, is there. Okay? Then you have the Langerhans cell and other dendritic cell neoplasms, Langerhans cell histiocytosis, Langerhans cell sarcoma, other dendritic cell neoplasms, that's indeterminate dendritic cell tumor, which we've already talked about, and interdigitating dendritic cell sarcoma, which belongs in this overall general group of Langerhans cells because they come from that one precursor, which is CD1A positive, okay, unlike the others which are CD1A negative. And then you have the histiocytic neoplasms, which, as I told you, belong in that macrophage group. Here you notice they're not calling them macrophages, they're calling them histiocytes. That is juvenile xanthogranuloma, Erdheim-Chester disease, Rosai-Dorfman, they call it Rosai-Dorfman, they haven't yet changed it to Daytome disease, ALK-positive histiocytosis, which is a new thing that has been added, and histiocytic sarcoma, which is, we used to call malignant histiocytosis once upon a time. So 2 new additions. I can't say that I have come across this, but perhaps during, during the question and answer session, I will ask Sumit, or if Sumit would like to answer now, whether he has come across mature plasmacytoid dendritic cell proliferations associated with myeloid neoplasms.
We have, Anita.
Yeah, Sumit?
Yes, we have.
Okay.
We have detected mature plasmacytoid dendritic cells on flow associated with myeloid neoplasms.
All right. And do they add to the severity of the disease, or they're just a reactive product?
I mean, do not know much about it, but I can't say they add severity of the disease, but this association is new for us to understand. But we do pick up these cells now.
Yeah, so then this is something that I would never be able to pick up, because it's essentially picked up by flow cytometry and not by a histopathologist just looking at bone marrow trephine biopsies. All right, thanks for that, Sumit. And ALK-positive histiocytosis, yes, we have seen that and also published on that. Now, what about the stroma-derived neoplasms of lymphoid tissues? Now, there is a separate group in the WHO, and most of them are the same as they were in the first part of it is most of them are the same as they were in the WHO 2016. But now, many of these things, which we considered were tumors of mesenchymal type, not anything to do with lymphoid tissue, although they did occur in lymphoid tissue, like intranodal palisaded myofibroblastoma, okay, has now been put. I don't think it will appear, or maybe it will be you will be asked to refer to this in the textbook the WHO book on soft tissue tumors. That's where it used to be, intranodal palisaded myofibroblastoma. Now it has appeared in the hematolymphoid 5th edition of the WHO. Then look at these splenic tumors, okay, splenic, because it's been realized that these splenic vascular stromal tumors are they don't occur anywhere else. They're seen only in the spleen, and the spleen being a lymphoid organ, these vascular tumors are probably best regarded as something to do with the lymphoid tissue, particularly, as I've said, and I've exhorted all of you to read about what the spleen was the function of the spleen originally was. So literal cell angioma, I can't say that I have really seen a case except in some slide seminar or something. Splenic hamartoma, yeah, that one does come across occasionally. But yes, SANT, this is what is called SANT, sclerosing angiomatoid nodular transformation of the spleen. If you happen to be in a high throughput lab or you're doing second opinion work, yes, you do come across these, and sometimes you will see it even in your everyday practice. Okay, so now we have done this WHO, but I don't know how many of you know there is a group which is called the International Consensus, calls itself International Consensus Classification. They have come up with, and they also have a classification of lymphoid and myeloid neoplasia, and they have a chapter on histiocytic and dendritic cell neoplasms, which is almost identical to what was there in 2016, except for these 4 different, and they don't separate the mesenchymal type cells from the myeloid cells and put them in 2 different categories. They just have this chapter on histiocytic and dendritic cell neoplasms, and these are the 4 things that they have added. Okay, indeterminate dendritic cell histiocytosis, which was not an entity before, ALK-positive histiocytosis, fibroblastic reticular cell sarcoma, and EBV-positive inflammatory follicular dendritic cell tumor, which was there in which people have been recognizing. Okay, so now that's the classification issue, but you have to understand that these are classifications that practicing hematologists and practicing pathologists have got together and put up. But there is a different way of looking at this, and the way that it is looked at in a different way is by the Histiocyte Society. Now, there is a very vibrant society called the Histiocyte Society, and they look at the classification of these accessory cells in a completely different way. Okay, they don't just give them names and all, although you can see that there are overlaps, and structurally the classifications are not very different. But here they have got 5 groups. Okay, they have the L group, which is Langerhans cell histiocytosis. Can you just mute your somebody's got a
There's an echo.
mic. Yeah, because there's an echo. Yeah. So there is the L group, which is called which has Langerhans cell histiocytosis in it. There is this indeterminate histiocytosis, and then it has Erdheim-Chester disease. Now, as we can see, Erdheim-Chester disease had nothing to do with Langerhans cell histiocytosis. Look at this little diagram that I put up. It's just a copy of what I talked to you about. See, this is a macrophage group where you expect to see Erdheim-Chester disease, and LSH is the one which is CD1A positive. These are CD14 positive. So why have the Histiocyte Society put them all in one group under the L group? I will tell you in a minute why they did that. Okay. Then you have the C group. What's the C group? It's cutaneous, because these all affect the skin. They may affect some other site, but their primary affect, where the primary occurrence of these lesions is the skin, and therefore cutaneous. And the example of this is juvenile xanthogranuloma. Then, of course, you have this Rosai-Dorfman disease, which is just called R. So that's the R group. Then you have the M group. You see that over here? And I showed you 3 arrows: malignant histiocytosis or histiocytoma, Langerhans cell, it is interdigitating dendritic cell tumor. When any of these tumors is malignant, then that goes into the M group as far as the Histiocyte Society is concerned. And there is one group over here, which perhaps is not considered to be a tumor, but that is very much in this classification of histiocytoses and neoplasms under the Histiocyte Society, and that is H. And what is H? It is HLH, and that is hemophagocytic lymphohistiocytosis. Okay, so they have a separate which is not there in the WHO or in the ICC, at least not under the histiocytic and dendritic cell neoplasms. Now, I'll just go through this a little because those of you, and maybe as young students, you may not wish to get into this, but sooner or later there is going to be a merger of the way that those of us who practice tissue pathology, and those who practice, pathology which involves flow and a whole lot of other things, there will be a merger of their thoughts. And that's why I thought it was worth, for those who perhaps are not students, but who might like to know what's going on in the world, that as to why LCH and Erdheim-Chester disease, one being composed of dendritic cells, the other of macrophage type cells, completely different immunophenotype, why are they put in one group? And the answer is down here. All right, histiocytoses with the BRAF with V600E or MAP kinase pathway derangements, both of them have this. Okay, and there are at least 20% of patients with Erdheim-Chester disease also have Langerhans cell histiocytosis. So it's not just a coincidence that once in a way you get the two things that occur together. Okay, and both conditions may be associated with similar clinical complications such as diabetes insipidus or neurodegenerative disease. So from the practical point of view, from the clinical point of view, this is the Histiocyte Society has grouped Langerhans cell histiocytosis, which I'm telling you does not share a morphology or immunophenotype with Erdheim-Chester disease in one group, right? But what they do share is a BRAF V600E or some other MAP kinase, because the BRAF V600E is a common mutation that is present in the MAP kinase pathway. It's present in so many. It's one of those mutations that is very common at this particular site. Okay, and not just in histiocytosis. You know that in papillary thyroid carcinoma you get the BRAF V600E. And would anybody amongst my 5 students tell me where else they might have heard of BRAF V600E? Or maybe somebody will write it in the chat box. I told you papillary thyroid carcinoma is one. Yes, so I said that papillary thyroid carcinoma. Also, Langerhans cell histiocytosis, Erdheim-Chester disease. Anybody would like to venture where you get BRAF 600? Melanoma, first class, yes, melanomas. And the reason for knowing all this is that perhaps this particular mutation can be targeted. It doesn't help with papillary thyroid carcinoma. Vemurafenib does not work. It works beautifully in melanoma, but it does not work. Yeah, but it does work when required in the Langerhans cell and the Erdheim-Chester disease. Right? Then we come to the R group histiocytosis, and that is, as I told you now, called Rosai-Dorfman-Detome disease, and you spell Detome Destombes. That's the funny French way of pronouncing, where you don't pronounce every letter. So that's Rosai-Dorfman-Detome disease, and we know how we identify it. Emperipoiesis, strong S100 protein positivity in the histiocytes, and then negative for CD1A and Langerhans. Okay, but just like you see 20% of Langerhans cell histiocytosis associated with ECD or vice versa. It's strange, but there is some RDDs that are associated with either Langerhans cell histiocytosis and or Erdheim-Chester disease, and there is a very fascinating group of cases, almost all in males, okay, with this particular mutation, MAP2K1, in which you get Erdheim-Chester disease and Rosai-Dorfman disease in the same individual. And notice something very interesting, okay, that not only are they males, but they had testicular infiltration by Rosai-Dorfman disease, not by the ECD-like picture, but by Rosai-Dorfman disease with the S100 protein positive, because ECD is not, that is Erdheim-Chester disease is not S100 protein positive. So it's an interesting thing, and they wonder why this affects the testes, and it's possible that, there is this pathway, that is the MAP2K1 pathway, is involved in the maintenance of functional population of adult latex cells. May not be in humans, but certainly it has been in mice. And they had 13 cases. And now you find individual case reports of this very peculiar arrangement. Okay, we come to the C group, that is the cutaneous group. And I told you that juvenile xanthogranuloma, there's some adult xanthogranuloma, solitary reticular histiocytoma. And when you have a cutaneous Rosai-Dorfman disease, it's S100 protein positive and everything, the Histiocyte Society puts it into the cutaneous group and is not put into RDT because of different behavior of this. So when you think about it, this is the M group. Anything that is malignant, okay? You can have primary malignant histiocytosis, also known as malignant histiocytoma, in the skin, lymph node, anywhere. Or you can have it secondary to a follicular lymphoma, to lymphocytic lymphoma, hairy cell leukemia. Victor syndrome is another, when the CLL transforms into something that has a different lineage altogether. All of these are considered under the M group histiocytosis, okay? So you can have any subtype which overlaps between the primary type of MH or the secondary type of MH. I'm not going into HLH because I think it's not part of this whole thing. But if anybody wants to know any of these, please feel free to take screenshots or whatever you want even if you're looking at a replay. Now, there are some common immunohistochemical markers that pathologists use, and I dare say that they are also used in flow cytometry, although there are huge numbers of other markers that can be used in flow cytometry, and these are they, all right? So this is Langerhans cell, this is the interdigitating dendritic cell tumor, this is the FTC or follicular dendritic cell tumors that have the macrophage type lineage, and then the follicular fibroblastic reticulum cell sarcoma, also known as SERC, and I'll tell you a little later why. And so these are the markers. CD1A, S100 protein, Langerhans, you know that it will be present over here. Occasionally, what defines the interdigitating dendritic cell tumor is S100 protein. Okay, you can get S100 protein also in these, and you know that Rosai-Dorfman disease is defined by S100 protein macrophages. Right? CD68, yes, in both in the ones that have the macrophage lineage. Occasionally, you will see it in the Langerhans cell, and that's when you have this problem, and you call it an indeterminate type of dendritic cell histiocytosis or a dendritic cell tumor. CD163 is a good marker. It's very sensitive, but it's not as specific as CD68 if you're using the PGM1 antibody. Okay. CD21, 23, and 35 are the iconic markers for follicular dendritic cell tumors. Sometimes they may be expressed in the fibroblastic reticulum cell tumor. Now, CK and SMA, I'm sorry, this should have gone into this column, are often CK and SMA are expressed in the follicular reticulum cell tumor, and that's why it is often called the cytokeratin expressing reticulum cell tumor, or cell. And there are two markers over here, and I've put them in red, CD4 and CD31. Now, can anybody tell me, any of you answer, what do we normally use CD4 to delineate? Yeah, Gorik? What does CD4 normally mark? Or if people want to write in the chat box, that's also all right. Vivian, do you know what CD4 marks?
Helper T cells,
Whoever is it, Gorik, you Gorik, yes?
Helper T cells.
Helper T cells, yes. We're doing it all the time in patients who have have HIV, AIDS, etc., we do CD4, CD8 counts, right? So it is a helper T cell, and yet it is regularly expressed in histiocytes. Okay, mainly those of the monocyte macrophage system. That CD4 is expressed there, and one has to be careful when you are evaluating CD4 in a lymph node which has got a lot of histiocytes, that you're not, and you are wanting to explore the expression in lymphocytes, that you are not mistaking the histiocyte expression for lymphocyte expression. All right. Now, somebody else, Swati, tell me what is CD31? Where is CD31 expressed? Normally means yes. CD31 is expressed in. Do you know where it is expressed, Swati?
No.
No, you did. All right, Lydia. Lydia, you can hear me?
Platelets.
Yes. In what? Sorry, Lydia, I didn't catch it.
Platelets or endothelial cells, I mentioned.
Platelets or endothelial cells, really? So yes, in endothelial cells. Yeah, CD31 is expressed in endothelial cells, very good. But it is also expressed in macrophages, all right? So one has to be careful, again, when you are evaluating a tumor and you see a lot of CD31 and other endothelial markers like 34 and ERG are not present, that you cannot jump to the conclusion that this CD31 is an endothelial marker, okay? So I just put this up over here because it's part of our overall knowledge as to what markers are expressed and in what kinds of cells. All right. So now let's start with the cases. Now, who would like to take case one? I'll just go in order because Gaurik is first on my list. So Gaurik. Okay, come on. Will you read this history out and then let's see the case? Yeah.
Sure, ma'am. Yes. So the case says it was a 48 years old male who presented with a cutaneous swelling on the left thigh. We received a white excision of the thigh lesion. The skin showed a nodular growth measuring 5 into 3 into 1.5 centimeters.
All right. Very good. So now let's look at this thing. Come on, Gaurik.
This H&E stain section, it shows sheets of mostly monomorphic sheets of cells which have an abundant eosinophilic cytoplasm, and it has oval to rounded and a few spindle-shaped, like some of the cells, most of the cells have oval to rounded round, while some of them have spindle-shaped vesicular nuclei with prominent nucleoli, not a very prominent nucleoli, and the cytoplasm is eosinophilic and it is quite abundant. Also, we can see some amount of lymphocytic infiltration, and a few mitotic bodies can also be appreciated in the figures.
Mitotic figures, right? Yes, we call them mitotic figures. We don't call them mitotic bodies, right?
Yeah, sorry, yes, and it also has a keratinized stratified squamous epithelial kind of a lining as well.
Lining? No, this thing is the skin, for God's sake, Gaurik. So this is not lining. This is the skin, and this tumor we know. You just read that, right? Had a lesion.
Yes, ma'am.
Skin of the thigh. It's anyways,
Yes,
you can see that it's on the skin of the thigh. It's
yes, it's a skin.
Divya, you're next on my list. Do you agree with everything that Gaurik said? Just to recapitulate what he said that there are these cells which are have got round or spindle cell nuclei, eosinophilic cytoplasms. He saw that they were in mitoses, and that he saw skin. Okay, keratinized skin. Is there anything you can improve upon, Divya, or you agree entirely with what?
Ma'am, hyperchromatic nuclei, high cytoplasmic lesion.
That's it. Okay, very good, Divya. Anything else you want to say?
If I can just add, I can also see some amount of.
Now. 1 minute.
Sorry, I'm so sorry.
Let's go to Swati.
Yes, ma'am.
Yes, Swati. Tell me anything that you want to add to what Gaurik and or you're happy with what they said. All that Divya added was a high NC ratio.
Yes, ma'am.
Anything you want to add, Swati?
Ma'am, the epidermis is keratinized.
Thank you. He said that. Gaurik said that. Okay, Oindrila.
Ma'am, there are macrophages.
There are macrophages. Why did you say that, Oindrila?
I can see some.
Macrophage out to me, Oindrila. You can just ask for annotation. You tried that, no? You know how to do that, don't you?
Yes.
Yeah. So,
There are some.
1 minute, Oindrila. I want to see those macrophages that you saw. So can you please ask for annotation?
Ma'am, just 1 minute.
What?
Yes,
See that little squiggle or not, Oindrila? To the right.
Yes, ma'am. Yes, ma'am.
Very good. So just there you go. Now come on, Oindrila.
Ma'am,
Show
these
me the
areas.
macrophages.
Wait, ma'am. Ma'am, please.
Just you've drawn a very thin red line which I don't think anybody can see. Can you just change the color and make it dark blue or some other color?
Ma'am, like, wait, ma'am.
Just go and take a pen and put it on the
Ma'am, these
color.
areas.
So you think that you saw this one macrophage, or are there many macrophages?
There are.
There are. Okay, why did you say that was a macrophage, Angela?
Because it's a bit of a light eosinophilic or foamy type.
Oh, a macrophage with a light eosinophilic and foamy type. All right. Okay, now let's come to Lydia. Lydia, do you agree with what Oindrila has said, what Gaurik and Divya and Swati have said? And I just again refresh your memories that what Gaurik said was that he saw cells with round nuclei or spindle-shaped nuclei and pink or eosinophilic cytoplasm. Divya added that there was high nuclear cytoplasmic ratio. Both of them saw mitotic figures. They talked about keratinization of the overlying skin, which to me is par for the course. Of course, if there will be keratinization, this happens to be skin. Okay, that's what Swati added to this thing. Anything else you want to add, Lydia?
Some grooving of nuclei.
Lydia, full marks. These are not round nuclei. These are not spindle cell nuclei. All right, Gaurik and Divya and Oindrila, Swati, you don't see that these nuclei are so tremendously grooved. Okay, can you see this over here now?
Yes.
Right, I'm just circling one, but now all of you look everywhere. What was going on in the chat box, Bushra? Was anything going on in the chat box? No, everybody's lazy.
Yes, ma'am. Lots of comments in the chat box.
What are the comments in the chat box? Tell me.
Yes, ma'am. Someone has mentioned grooving of the nuclei.
It is extraordinarily grooved. Now you want to see a nucleus? Oh yeah, where did my thing go? 1 second. Huh? Let me just.
Yes, ma'am. Dr. Babita has commented.
Dr. Babita is she's very good. Now let me just pull this down. I just want to get my. Oh God, this is really okay. Here I am. You want to see something here? Look at this cell. And that's not the only cell. I've shown you lots and lots of cells. Just look carefully at this. Okay, there is definite grooving of the nuclei. And Gauric, I'm amazed, and all of you. When you look at skin, I don't know if you've ever had the chance to look at skin, and when there is a lymphoid or any other infiltrate, and this is an infiltrate. Do you agree with me, Gauric, that this is an infiltrate?
Yes, ma'am.
Yes. So when there is an infiltrate in the skin, what is one of the things that you do, which you should be doing, Gauric? What should you be doing? Looking to see? Should you not be looking to see that what is the relationship to the epidermis? Have you heard of such a thing called the Grenz zone?
Yes,
Who
ma'am.
has heard of the Grenz zone?
Yes, ma'am.
Yes, ma'am.
Who's heard of it?
Yes, ma'am.
Yeah, a female voice also said yes, ma'am. Who's that?
Ma'am, Oindrilla.
Oindrilla. Now, what is that Grenz zone in Oindrilla?
It's like a clearing, like at the dermal junction.
It's
Like
not
just
clearing.
below the,
It
it's just
is-
like
It is
it's
a
just-
it is a cell-free zone.
it's a
That is
sensory
just
below the
dermal
epidermis.
Epidermis.
junction. Fantastic. Yes, Oindrilla, that's what it is. And when there is no cell-free zone, we say there is no Grenz zone. It means that infiltrate is impinging on the epidermis, and you can see that here. No, you see this? There is no difference. There's no distinction. There is no cell-free zone. Do you see that? Or let me see if I can get a get a pointer that is laser. Yeah, do you see? If you follow this, you see that there is no cell-free zone. You're getting the cells that are in the dermis freely infiltrating the epidermis. Do you agree or you don't agree?
Yes, ma'am.
Now that's a very important observation. Where do we use it in everyday histopathology? Why do we look for the Grenz zone?
Lepromatous
Symptomatic leprosy.
In what sort? No, I didn't hear. Both of you spoke together.
Lepromatous leprosy.
Lepromatous leprosy. Okay. What else?
And, like, clear
Lymphoma.
Lymphoma. Which lymphoma? Mycosis fungoides.
Cutaneous T-cell lymphoma.
Yes, mycosis fungoides.
Mm.
You do not have a Grenz zone. The
Yes, ma'am.
infiltrate actually crosses that dermoepidermal junction and is present in the epidermis. So there's lots to be seen over here. And what you see are grooves everywhere. Grooves. These nuclei are not round, Gauric, please.
Yes, ma'am.
They are not spindly, Gauric. Do you agree?
Yes, ma'am.
Good. They have very distinct grooved nuclei. Okay, you see them everywhere. I mean, I can't go on pointing all of them out. There's no Grenz zone, and it is mitotically very active. Yeah. Okay. Now this is the lower part of that. That was at the superficial level. And you see, what will you see over here, Gauric? Since you're doing this, what do you see?
So now we see clusters of adipocytes all over, and besides that, we also
clusters of adipocytes are, Gauric. This is the deep part of that skin.
Deep
So
part.
what is,
Yes, ma'am.
what is it? You see these? You see the collagen bundles over here?
Yes, ma'am.
The thick ones?
Above the
So what part of
papillaries,
the
yes,
skin? What part of the skin is that? Where you see these thick collagen bundles? What part of the skin is that?
the dermis,
Yes, it is the reticular dermis.
Reticular
You have the papillary dermis.
reticular,
You have the
and the
reticular
reticular
dermis.
dermis.
And you have what is called the papillary reticular interface. Now, that's a different story for skin pathology. But you have here the reticular dermis, in which you have, and the thigh is a good skin to see this. You don't see the distinction between papillary and reticular in all parts of the skin. But yes, the skin of the thigh, the abdomen, the hand, and I'm not talking about the hand, the arm, all have very well-defined papillary reticular. Okay, the reticular dermis you saw in the previous thing. Sorry, the papillary dermis, and this is showing this heavy sheet-like infiltration of the cells, which we just described, right? Yeah, they're all singly placed, but in sheets. They're not sticking together. All right. Now here you have a similar thing, but you have now the reticular dermis. That's the deep part of the skin. And then what do you think this fat is, Gauric? What comes
And it is
from
subcutaneous fat.
Wonderful. It is the subcutaneous tissue. So what you can see is that those same cells, of course not at the same power, are infiltrating. That means right from the dermoepidermal junction, also the epidermis as well, right through the whole skin into the subcutaneous tissue. All right. So we've got a really thick infiltration. Now there's also something interesting here, Gauric. You said that there were nests of adipocytes. What exactly did you
Yes.
mean? What did you
Ma'am,
mean?
collections of adipocytes are named.
The adipocytes are the normal part of this structure, isn't that right? Because the subcutaneous
Yes,
is
it is.
normal. So you can't say that I have nests of adipocytes.
No,
No. So what is it that you are seeing? That's a very interesting phenomenon, Gauric. And if you are not able to identify that, let me go to Divya. Come on, Divya. These are not nests of
Pancreatitis.
Hmm?
Is it pancreatitis?
No, it's not a paniculatus because it's a tumor. That is infiltrated.
Subcutaneous infiltration.
Yes, it is not just subcutaneous infiltration, but this is what is known as permeative infiltration. Now, this is important. What do we mean by permeative? All right, if you have a sieve and water goes through the holes of the sieve without destroying, it doesn't destroy, the matrix of that sieve. That's permeation, right? But there are other kinds. Say you take a big stone, and you force it through that sieve. You know, it's a sieve, Chinese. You know what, like a tea strainer or whatever
Yes,
you want to call it, a strainer. Okay, if you take a heavy stone and you force it through that, the whole sieve will give way, right? That is not permeative infiltration. But when things are going through, leaving the structure intact of the sieve, and this is what this is doing. So this is a tumor that is permeating through the subcutaneous tissue. It is also permeating through you can see the reticular dermis. It's pushed the fibers apart. It has not destroyed the fibers. It's not destroying the fat. Okay, not like some carcinomas and other such things do. This is permeative infiltration. So remember, whenever you're looking at infiltration, this may be applicable here. It's applicable at all sites. Ask yourself what kind of infiltration it is, wherever it is, whether it's in the liver or it's in the kidney or it's in the skin or it is anywhere else. Is this permeative or is it destructive? Okay, destructive infiltration has got its own diagnostic connotation. Permeative infiltration occurs mainly with hematolymphoid or hematolymphoid tumors. Okay, so whether it's lymphomas or and today we're talking about histiocytes or myeloid tumors or anything else, they permeate. They do not destroy. But when you have carcinomas and sarcomas and lots of other things, except one carcinoma which does permeative infiltration. Can you tell me which one or two or very few carcinomas that do permeative?
Basal cell carcinoma?
Basal cell carcinoma, please, Gauric.
DFSP.
DFSP, no. Swati, who was that? Swati? Andrila, Lydia. Now I'm just asking you, Lydia, look, or all of you, look at this. Okay, what does it remind you of? If you didn't know that this was a histiocytic neoplasm, because we're talking histiocytes now, what would it remind you of? And I told you that this was in the breast. What did you think of?
Lobular carcinoma.
Lobular
you
intracranial
are.
arrangement, yes.
Exactly, and lobular carcinoma of the breast, signature cell carcinoma of the stomach. Okay, these are tumors that have lost their connections to each other. No, the cells no longer have connection to one another because they've lost their. Sorry.
Ecadin.
Yes, they've lost ecadherin, which is what is ecadherin?
The cementing molecule between two cells.
Adhesion bond.
It's an adhesion molecule.
Adhesion.
So that is how, and you know that lymphocytes do not have the kind of adhesion molecules that you expect to see in lymphocytes or histiocytes or whatever. Have got completely different adhesion molecules from what you see in normal either sort of carcinomas. That's what makes a carcinoma stick together, and lymphocytes and other things do not stick together. And that's why you get permeative infiltration in these lymphocytes and histiocytic and myeloid disorders, and in those that have lost their ecadherin. If it's a carcinoma, yeah, they're adhesion molecules, and therefore they permeate. Now, have you understood the story about the permeation and destructive infiltration? Yeah, Gaurik, that is something that one had to note in this particular thing. All right, now, Gaurik.
Ma'am, eosinophilic infiltrate is what I can see, I think.
Let's see an eosinophilic infiltrate. What do you mean by eosinophilic infiltrate, Gaurik? Where is an eosinophil? Can you show me an eosinophil, please? Yeah, show me an eosinophil. Are you talking about cells with eosinophilic cytoplasm? Oh my God. So now there is one cell here which has got a little pink cytoplasm and you're calling it an eosinophilic infiltrate. Gaurik, we're talking about thousands of cells in this, and you pick on one eosinophilic cell that you see which has an eosinophilic cytoplasm, may not even be an eosinophil, and you say that's an eosinophilic infiltrate.
No, not infiltration.
So what are you seeing over here? This is a higher power than what we were seeing before. So what are you seeing? Anything different from what we were seeing before? Sheets and sheets of cells, yeah, which have what? Here you may say that some of them look elongated, the nuclei are kind of stretched out, but they're certainly not spindle cells. Okay, they look a little spindly because to be a spindle cell, a cell must have a long elongated nucleus. The cell must be elongated and it must have an elongated nucleus, a spindle cell nucleus. No, but you see all these cells with grooves and there are so many mitotic. It's a vesicular nucleus which has grooves and there are, of course, it's got eosinophilic cytoplasm and you can see the number of mitoses, huge numbers. Okay, very good. Now, what do you see here, Gaurik? What part of the skin do you think this is? It's dealing with the skin, right?
Yes, ma'am.
So what are these pink things that you see, Gaurik?
Collagen fibers.
Yeah. So which part of the dermis is this?
Reticular.
Reticular dermis. Okay. So in addition to all these vesicular nuclei with grooves and you can see not only grooves but you can see clefts in these nuclei, yeah? Little horseshoe-shaped nuclei, etc. You have got multinucleated cells, right? Over here. So there's pleomorphism in this tumor, and look at the number of mitoses. Huge numbers of mitoses. In this one field, you've got 2 mitoses, maybe more. Which okay, good. Here's some more, and you see the same things again and again, except that you're now seeing it at high power. Now, Gaurik, you'll have to tell me this. You see the cell now that I pointed out?
Yes, ma'am.
What would you say about, how would you describe the nucleus of that cell?
Ma'am, the nucleus of the cell is vesicular and it is sort of cleaved, or it has sort of it has a partition in between. It is sort of a cleaved nucleus, and it is vesicular.
All right, Gaurik thinks that it looks like a cleaved nucleus. Yes, it is. It has a groove through it.
Groove,
But
yes,
is there
groove nucleus.
any kind of description that you would like to put to it, Gaurik?
Like a coffee bean, if I can say.
Coffee bean nucleus, excellent.
Yes.
Does everybody agree? Yes, it's a coffee bean nucleus, or somebody might call it a walnut. No, it looks like
Walnut,
a nut. Yeah. So now you see that? That's a coffee bean. You see the coffee beans? Yeah,
Yes,
that's the nucleus that is coffee bean. Somebody might consider it to be a walnut-shaped nucleus. All right, now Gaurik, what
Yes,
would you say is this nucleus like? You see, I put on. There's another black arrow that has turned up. Can you see it, Gaurik?
Yes, ma'am, I can.
Yes. Okay. Come on. What does it look like to you?
Ma'am, it is vesicular again, and it has some basophilic
Shape of the
restrictions.
nucleus. That was coffee bean.
H-shaped
H shape. Does it look like an H to you?
horseshoes, I can say.
Horseshoe, yes, very good. Like a horseshoe. Anybody else wants to offer something? Divya, horseshoe, very good. Anybody?
Indented.
Indented, Acha, Swati. Yes, no? Oh, Indrila, I think you said indented, did you? I don't know. Lydia?
I don't indented.
Indented, really? You know what it looks like?
And we have an answer in
Yes, tell us.
embryoid shape.
Embryoid.
Debated
What's
the
this
outcomes.
embryoid? Now, where have you heard of an embryoid nucleus? Any one of you has heard of an embryoid nucleus? No? You know that it is very typical of an anaplastic large cell lymphoma. No?
Okay.
And if you look around here, there are all kinds of coffee beans and embryoid and curled upon themselves all over the place. So this is not an anaplastic large cell lymphoma. It is not. All of these cells, yeah, I suppose could be, it can be a lymphoma like an anaplastic large cell lymphoma, but it is not. Okay, where do you see coffee bean and walnut-like nuclei? And when we are talking about histiocytes and dendritic cells, yes, Gaurik? In what tumor will you see that? No, whenever we talk of walnut cell, coffee bean, etc., there are some tumors that do it. See, this is a very high-grade tumor. We know that it's showing necrosis, but all of the nuclei have that appearance.
DLBCL, ma'am?
Sorry, DLBCL. Oh, well,
Yes.
yeah, some DLBCLs do have them. I'm not saying not. Yes, so this DLBCL could be one of those things. But we're talking about histiocytes and dendritic cells.
Histiocytic sarcoma.
Anybody would like to answer that question, or is anybody in the chat box saying something? Look at these nuclei.
We have an answer. Dendritic
Yes.
cell sarcoma. Dr. Babita.
What dendritic cell sarcoma?
Yes,
Which dendritic cell? Which
Langerhans
dendritic
cell.
cell?
The Langerhans cell.
We also have an answer in the chat box.
Yes, those have a coffee bean or a walnut-like nucleus. Okay, so we have got a Langerhans cell proliferation, which is obviously malignant. Okay, and it is full of mitosis, necrosis, and everything else. And even if you were thinking about various differential diagnoses, it would be maybe, myeloid lineage. Maybe these are all monocytes of one kind or another. Histiocytes, dendritic cell lineage, in which case it would be a Langerhans cell thing, or it could be AL cell, because we saw some so-called hallmark cells or whatever you want to call it. It is very unlikely to be of epithelial lineage. Okay, some kind of immunohistochemistry has to be done, and whatever it was, which was done. And actually, one just has to prove what one already knows. Okay, and you can see here that this is S100 protein positive. This is CD1A positive. It's a lovely membrane positivity. Okay, CD1A must be membrane. S100 protein could be cytoplasmic, but it is also should be nuclear. If you are thinking of Langerhans cells, sometimes you have like we will see in Rosai-Dorfman disease, you may not get the nucleus that is positive for S100 protein, and this is MIB1. In the days when we had this case, Langerhans was not available. That's CD207, but I don't think we needed it in this particular case because this is a Langerhans cell sarcoma. Okay, so in the WHO classification, it would be called a Langerhans cell sarcoma. In the ICC, it would also be called that, but it would be a group M histiocytosis in the histiocytic, in the histiocyte society grouping. Why is it called group M? Because it's malignant, right? So the M stands for malignant, and it doesn't matter which histiocytic group it is, it would be called group M. Excellent. That's very, very good. So now will one of you answer this question, or some in the chat box? A firm diagnosis of Langerhans cell histiocytosis rests on what? Expression of S100 protein alone, expression of CD1A alone, expression of, yes, which one?
Fourth one.
Expression of Langerhans on IHC and Burbeck granules on electron microscopy.
Excellent. What do they say in the chat box?
D.
Excellent. Very good. And now you can see Burbeck granules, which are these racket-shaped granules. They're actually indentations of the nuclear membrane, the cytoplasmic membrane, as you see, as it goes in there. And then you have all these, you may or may not have Langerhans, and everybody doesn't have Langerhans, and I think that Langerhans is just the icing on the cake. But if you have S100 protein and CD1A together, they're usually sufficient for the diagnosis in routine practice. And I'll tell you when you have to be careful about just using these two together. And you can't use them alone because S100 protein is present in so many other different cell lineages, and CD1A, I'm sure you may not be aware of it, but it is regularly expressed in T lymphoblastic lymphomas. Okay, now here is classical Langerhans cell, which I got from the net, but our case was even more classic than this with the coffee bean nuclei and other things. And we've already talked about the BRAF V600D. Now here is a case in point. Okay, this is something that is in the skin, and it is a classical Langerhans cell histiocytosis. You can see all the grooves, you can see the coffee bean nuclei, the CD1A, and you can also do BRAF 600E. Okay. There was something else that I wanted to tell you about, but it'll turn up a little bit later. Okay.
We have a question related to this case.
Yes.
The question is from Dr. Regi. Can we distinguish it from melanoma?
Of course, we can distinguish it from melanoma. Why? Does melanoma have CD1A? Certainly not. And melanoma will have HMB45 and melanA. I didn't quite understand the crux of that question. Can he just type in, he or she, type in why they would think that you would mistake it for a melanoma?
Well, initially, also many people were typing melanoma in the chat box. Initially, when you showed the first picture, many people typed melanoma as diagnosis.
Why would you get grooved nuclei and all of those things in a melanoma? You wouldn't know.
She's asking morphologically. I think they're confused.
Even morphologically, does this look like a melanoma? Will somebody tell me what is the morphological distinction or the morphological similarity with melanoma? Does this have huge, sort of nucleoli? Is this, got nice distinct cell borders with a very, dense eosinophilic cytoplasm? If somebody can tell me why they think that a picture like this or whatever we saw before could be a melanoma, then I would be very happy to tell them. How many grooved melanomas has anybody seen with grooved nuclei, coffee bean nuclei? Huh? I don't think it's a melanoma at all. Okay. If there is a question, we'll take it later. We'll take it later in the. All right. Okay. Good. So this is BRAF 600D. All right. Let's. Somebody would like to take this particular thing now. Who will take it, Divya?
Yes, ma'am. 58-year-old male, paraffin block of a wide excision of a long-standing swelling over the foot.
Very good.
The outside pathology report mentioned it as well. Circumscribed mass 5 × 4 × 2 cm in size. The cut surface was soft to form and yellowish.
Right.
Case 2B, 80-year-old male, paraffin block of wide excision of a right foot. Site lesion were received. It was a 4 cm size solids and brownish mass.
All right. Very good. Now come on. Tell us now. You saw that previous case, right?
Yes, ma'am.
So is this similar in any way?
No, ma'am.
No. And both of them, you will see, are similar lesions, but this is just, they're just two cases that we had together. Yes, come on. In what way is it not similar at this very low power?
Ma'am, I can't recognize at low power.
I don't think that you need to recognize it, Divya. You just need to tell me in what way does it differ from what you saw of the cutaneous lesion in the previous case.
Ma'am, epidermis has keratinized epidermis stratified.
All right. Anybody else wants to help, Divya? Swati?
In case 2A, there's a distance between this epidermis and the.
Yes. So whether it's in case 2A or in 2B, this is a lesion that is not in the papillary dermis. You agree, Divya? Both of them are not in the papillary dermis, and there is a clear zone. I mean, this is not a red zone.
Yes,
this is in the deep dermis here. It may not be entirely as deep as it is in 2A, but it is in the deep dermis. So this lesion is not impinging on the epidermis. We're not even trying to find out what the nature of the cells are. We need. And I keep telling people again and again and again that at low power, there are some things that we have to appreciate. Number one, we answer the question. What is the question 5 questions that we answer? Number one, is there any normal tissue? And the answer to that question over here is yes. Is there any abnormal tissue? The answer is yes. What is the relationship of the normal to the abnormal? What is the relationship of the normal to the abnormal? Huh? What is the normal tissue that is present over here, Divya?
Ma'am, there is no atypical cells in here.
Oh, for God's sake, Divya, no. What is the normal tissue that is seen over here? Indra?
Ma'am, the epidermis.
It's not just the epidermis, it is skin.
Ma'am,
Right? What
skin,
is
yes, yes.
what is skin? Skin is epidermis and dermis. You don't think that there is a normal epidermis and a normal dermis? Of course there is. Yeah, even here you have a normal epidermis.
Yes,
and
ma'am.
you
The
have
epidermis is normal.
correct. So now what is the relationship of this abnormality with the normality? What would you say? Exactly what we said before, no? That these lesions, and we don't know what they are not situated or not arising from the epidermis. In fact, they're situated in the dermis, not in the papillary dermis, but in the reticular dermis. That's what we can see over here, as opposed to what we saw in the previous thing. What did we see in the previous thing? This was a lesion in sheets in the papillary dermis, yes or no? Yeah, and there was no gray zone. So that was the relationship of the abnormality to what was normal. Okay, the fourth question that we ask ourselves at low power is, what's the pattern of this abnormality? Divya, what is the pattern? In the last case, we saw it was in sheets. What do you think is the pattern over here? Is it in sheets or not in sheets?
Not, ma'am. Not in
Not in
sheets.
sheets. Acha, what kind of pattern is it then?
Uh,
It's not in sheets.
Ma'am.
Divya?
It appears as sheets.
Of course it is sheets. It is sheets. You
Okay,
can
ma'am.
see there is no pattern. There are no fascicles. There are no nodules. There are no palisades. There is nothing but sheets. That is what you are seeing at low power. Now let us see, as we go a little higher, it confirms the fact that this is in sheets. Yes or no, Divya?
Yes, ma'am.
Yes, now you describe what you're seeing, Divya. It's the same on both sides. So you can describe anything that you want. Come on, one, either 2A or 2B.
Sections, ma'am, sections show round blue cells with the,
What? Round blue cells.
ma'am, sorry, ma'am. Sections show some atypical cells with the hydrocollagenous tissue and case 2B in lymphocytic infiltration.
Why did you say round blue cells first, Divya?
Sorry, ma'am, because blue cells, I
Blue cells. What were you describing as blue cells, Divya?
No, ma'am, it's a mistake, ma'am.
Right, okay, but why did you make the mistake? Because if you know why you make the mistake, you won't do it again. So what were you describing? What is blue?
Ma'am.
It's the nuclei,
Cells.
right?
Yes, ma'am.
So this is a common mistake that students make. They look at the nuclei and describe it as the cells. And what you see over here, Divya, is that they are huge cells. They are
Yes, ma'am.
huge cells which have a clear cytoplasm, or in some cases even a cytoplasm that has got vacuolations.
Yeah,
And they are
yes, ma'am.
huge, and you have multinucleated cells in some places. You have cells which are couldn't have seen it in the previous slide. Okay, but these are very large cells. It's diffuse, and you started to say something, and that is that there were these very hyalinized bands that are separating these cells, which they're not nests of cells, they're just sheets, and these hyalinized bands are dissecting between these cells. Do people agree with me or not? Some of these hyalinized bands are actually outlining some of the cells over here. Okay, so that's what you're seeing. These nuclei are small. In many cases, some of them are multinucleated. Often they are vesicular, you can see that, but they also have very dense looking nuclei that you can see. Now look at them over here. The same thing that is being seen with a lot of hyalinization, connective tissue between. So that is what we are seeing in high power. And the histology is similar in both. You get this compartmentalizing, hyalinizing sclerosis. It's a very monotonous kind of appearance. Yeah, the cells are not all look the same, but if you go and look from area to area in each of the tumors, they look terribly monotonous. Okay. Yes, there is some dilated vasculature. There is large cells, abundant cytoplasm, multivesicular cytoplasm. Okay? Small little nuclei. They're vesicular with small nuclei. Okay. So what are the possibilities, Divya, you will think of?
Ma'am, ma'am, sarcoma muscles.
Sarcoma. Okay. Did you see mitosis, Divya?
No, ma'am.
Oh man, so a little odd, no, to think of a sarcoma if you don't have mitosis. Yeah, but it's an odd kind of tumor. Okay, but all that you can see that it's an abundant amount of cytoplasm and vesicular nuclei. You don't see too many grooves and other such things, but they're multinucleated cells as well that are seen in this particular thing. But we know that it is not likely to be epithelial. It's more likely to be something to do with the mesenchyme. And then you wonder, could it be a clear cell sarcoma? Could it be some epithelioid but not epithelial tumor of some sort? Could it be a follicular dendritic cell tumor? Could it be a pecoma? Do you know what is a pecoma? Perivascular epithelioid cell tumor, okay, which can be large, can be very clear, and so forth. So there are various possibilities that come to mind. And then you do a whole lot of immunostains, and you find that it's not clear cell sarcoma, okay? Because if it was a clear cell sarcoma, it should be S100 protein HMB45 melanate. Of course, it's not anything to do with epithelium or even epithelioid because it's not CKOE are positive. It's not a pecoma or an epithelioid sarcoma or an FTC because none of these markers, FTC should have been 21, 23, 35. CD1A is negative in this case. Okay, it's not a smooth muscle tumor, which could be epithelioid and look like this. Then somebody suggested, could it be a vascular tumor? All right, here we are, Divya. This is CD31. Okay, do you think it's a vascular tumor, Divya?
No, ma'am, CD31.
CD31 we said was, who answered that question, Indira? Who said?
Endothelial.
Yes. So it's CD31 marks endothelial cell. So do you think, Lydia, that this is a vascular tumor? Do you think so?
No, ma'am.
No, ma'am. Why?
Vascular channels are not there.
Vascular channels are not there. Well, if you look around, you see some things that look long, etc. But when you see that CD31 is outlining these cells, right? So could they be endothelial cells? Yeah. And what was that one thing in that table that I showed you? There were two things that were marked in red. Does anybody remember?
CD4 and CD31.
Very good. And and then we are doing a seminar on accessory cell lesions, right? So even that should prompt you to think that I can't call anything that is CD31 a vascular tumor unless I confirm it with another marker. So which other marker should I confirm it with? Divya? What are the other markers of endothelial cells? Lydia?
CD34.
CD34, excellent. And ERG, that's ERG. Okay, so here we are. Oh, I don't know why it's not moving. Now tell me, is ERG marked the cells? Divya, has ERG marked the cells?
Yes, ma'am.
It has. Can you show me what cells are marked by ERG? Just ask for annotation, please. Okay, now show me what are those cells that are marked. Show me the cells that are marked.
Yes, ma'am.
I have, you already got the annotation, right? Start again, Divya, because you asked too many. Now, no.
Sorry, ma'am.
Control. 1 second, Divya. I don't know what you did. Anyway, let me.
Yeah, ma'am.
Huh?
I can't do that, ma'am.
No, you can't do that because you did something that I can't now. 1 minute. Let me see. Press shift to end remote control. Okay, press shift alt. I'll have to do it. Alt and control. Okay. Yes. Oh, it's still.
Yes, ma'am. Yes, ma'am. Arrow.
Shift alt and what do I have to do? Alt and R. Have we got R somewhere that I have to? Yes. Come on now, Divya. If you're talking about these cells, Divya, what are they? What are these?
Blood vessels.
What are they? Divya, if you're going to muck up this thing again, now will you please show me what you're annotating? Yes. Now, what do you think that is, Divya? Are those
Ma'am,
cells that we are interested in? What are they?
Yes, ma'am.
Really, we are interested in those cells.
Nucleus.
So
Ma'am,
what-
nucleus. Nucleus, ma'am.
These are endothelial cells of blood vessels.
Blood vessels.
Yes, ma'am.
Okay, I am interested in these cells. Okay, are they
Okay.
positive? These cells. These are my tumor cells. So am I interested in the blood vessels, which will obviously mark. This whole thing is full of blood vessels, Divya, so it will mark. But what about all these other cells? Have they marked? All these cells, have they marked with
Mhm.
ERG?
Yes, ma'am.
Yes or no?
No, ma'am.
No, so then your tumor cells have not marked with ERG. So what does that mean? Divya, ERG is an endothelial cell marker. The internal control, which is the endothelial cells in the blood vessels, have marked. So your stain has worked. Okay, but the tumor cells are negative. So this cannot be vascular. So your 31 is marking something which is not endothelial cells. Okay, so your tumor cells are not endothelial cells. Have you got the point or not, Divya?
Yes, ma'am.
Now, if you go to CD34, which is this, again, the tumor cells are negative. Only the vasculature, that is the endothelial cells, are positive. So what is CD31 marking, please, Divya?
Ma'am, epithelioid cell, plasma cell.
Epithelial cells and plasma cells. Why would plasma cells mark with CD31? Divya, what did we say marked with CD31? Huh? We said histiocytes and dendritic cells mark with histiocytes mark with CD31. No, Divya. So this is obviously something that is not endothelial in nature. So this is not a vascular tumor. This is a histiocytic tumor. Okay, that's what we have come to know. So the answer to this, is this a vascular tumor because CD31 is expressed and yet ERG is not? The answer is not. There you are. CD31 is expressed in histiocytic tumors of the macrophage lineage. Okay, so now we go and find out, is there any other macrophage marker that is being expressed? And what are these markers? CD68. They're marking can you see this now? They have marked all those cells which were marking in CD31. Okay, you can see now CD163, which is another marker of histiocytes, has marked this particular thing. And so the final diagnosis, which in that we thought that was some unusual tumor of low malignant potential, which had histiocytic differentiation and derivation. Okay, until we put this up in there is an echo. Somebody's mic is on. All right. Until when we put it up in some kind of at a meeting, and somebody came up with this very interesting diagnosis, which I didn't make at the first instance. I knew that it was of histiocytic derivation, and this is a lipidized fibrous histiocytoma. Okay, and it is something that looks like a juvenile xanthogranuloma. And anybody who wants to go and look at this, if there are people who are interested, can look this up. And the only difference between a juvenile xanthogranuloma and this lipidized fibrous histiocytoma is that CYP4 and LCA would have been negative if we had done it in this lipidized fibrous histiocytoma and positive in a xanthogranuloma. But as far as I'm concerned, I believe that this is too narrow a way of trying to distinguish one from the other. I believe that this lipidized fibrous histiocytoma is probably a lipidized variant of dermatofibroma or possibly an adult variant of juvenile xanthogranuloma. Okay, but this is a classic case which is showing that CD31 is not being expressed as a vascular marker in this tumor. It was expressed as a marker of what, Divya? What was CD31 being expressed as? A marker of? Macrophages, histiocytes. Yes, so that is what it was, and then it also expressed CD163 and CD68. All right, now I don't think that you need to. All right, now who's going to take this one? I think that I will do this case because otherwise, we won't finish. And this is a 7-year-old male who presented with an acute abdomen, and surgical exploration revealed that he had not a very large, but it was causing obstruction involving the jejunum. Okay, now this 7-year-old was a survivor. At the age of 2, he was treated for T-cell lymphoblastic leukemia, and he had been in remission. So it was an unfortunate thing now that he came with this kind of tumor. And here you can see a portion of the jejunum. Yes, everybody sees the jejunum, and in the wall of the jejunum there is this tumor, which is again in diffuse sheets. There may be a little bit of nodularity, but that's because I think this tumor is being circumscribed by wisps of jejunal muscle. Okay, now you look at it, and there are two different appearances of this tumor. Here you have a very sort of diffuse sheets of cells which look like they may be lymphocytes in the sense that, or hematolymphoid in nature. On the other side, you have this, not the other side, that is this, but was intermixed. You had very spindle cells, but anybody with half an eye can see that this is a malignant tumor. There is no two ways about that. Okay, so I'm just showing you these two appearances in the same tumor. On one side, you see that it looks very spindly. On the other side, it looks like a hematolymphoid tumor. But once again, notice that there are grooves. There's multinucleation. I hope you are able to see that. Again, there is an echo which means somebody's. Can all of you mute yourselves, please, for a while? Yeah, so that the echo is. See again, you see now the grooves, so beautifully seen over here, and it is obviously malignant. There are mitotic figures on the left side, and here is a more spindly area on the right side, both being part of the same tumor. I'm just showing you lots of examples of this tumor. Now this spindly thing on the right side is now looking on. Can you see how many cleaves there are? And in some places, those who do a lot of lymphoma work will notice how much like like centrocyte nuclei they look, except there is so much cytoplasm. Okay, so centrocyte nuclei have this long cleaved kind of nuclei, but centrocytes do not have this much, this amount of cytoplasm. So you have round cells and spindle cells, and you have convoluted and folded nuclear shapes, multinucleated giant cells, some have an embryoid morphology. And then obviously we have to think of high-grade hematolymphoid tumor, ALCL. I don't think I would have thought very prioritized in ALCL. But yes, of course, it is neoplasm because of these folded nuclear shapes. All right, so we have to do immunohistochemistry, and we did it. Okay, high-grade hematolymphoid neoplasm. There's no c-KIT, there is no CD34, it's not a lymphoma, there's no 20, there is no 3, there's no TPT, there's no MPO, there's no CD30. Okay, all of these are negative. So very, very unlikely that it is a myeloid tumor, that it is a blastic tumor of some type, which is TDT positive, and there's no CD30. So it's not likely to be an ALCL. Yet this tumor is expressing this very, I don't use this marker very often, but it is a good marker if you are convinced that this thing is, belongs in this histiocyte, the myeloid or hematolymphoid or histiocytic group. Leukocyte common antigen is a very good way, which helps you in many instances. It looked very rounded and hematolymphoid-like, are very strongly expressing membranous leukocyte common antigen, which is also called CD45. And you have the spindly ones, yes, are expressing it, because you can see over here that there is a mitotic figure and that membrane is showing it. It's not very weak, it's not very strongly expressed there, but it is being expressed. And then it's not a lymphoma, it's not a myeloid tumor, so could it be a histiocytic tumor, all right? And then, it's very strange, but the ones that were expressing a lot of LCA didn't have too much 68, but the ones that were very spindly had a lot of CD68. But when you went to CD163, it was expressed diffusely in both of these types of the morphological types of cells in this tumor. There's no S100 protein, but there is a lot of lysozyme. Now, I didn't put this lysozyme in the main chart because lysozyme is not available with a lot of people. What I put in the chart were those that were commonly used markers. But if you have lysozyme, it's a good marker for those who are attending who do a lot of immunohistochemistry, and that's a good marker which can sort of just if your 68 is iffy or 163 is iffy, lysozyme sometimes comes to your rescue. Not always, but it does. And now here comes our famous CD4. Okay, just because it's CD4, this doesn't mean it's a T cell. It is now, CD4 is being expressed in this tumor, which we have already shown has expressed many different histiocytic markers. It expressed CD68, it expressed CD163, it expressed lysozyme, and here it is expressing CD4. And the mid one is extremely high, and this is a histiocytic sarcoma. Okay, so it's a strange phenomenon, but just like we said that plasmacytoid dendritic cell tumors may be associated with myeloid or proliferations with myeloid tumors, histiocytic sarcomas may precede or occur subsequent to malignant lymphomas, leukemias, MDS, or CLLs. That's the Richter syndrome. And there is a strange phenomenon that where histiocytic sarcomas are known to occur in conjunction with mediastinal germ cell tumors, most commonly teratomas. It's a strange phenomenon. I don't know what is the explanation for that, whether there is a stem cell there which is of myeloid derivation, which sort of it gives rise to these histiocytic sarcomas in the anterior mediastinum when you have a germ cell tumor. All right, so that, I don't think we'll discuss that further. I just wanted to show you how you can get a malignant histiocytoma that follows a known T lymphoblastic lymphoma, or it may follow any one of the ones that I showed you. I'll also do this one, right? And this is a 20-year-old male medical student who had an inguinal lymphadenopathy. He had no history of fever or weight loss or anything, but an FNE had been done of his lymph node, and it was said to be a non-Hodgkin's lymphoma. But when he had a CT scan, he had multiple lymph nodes, but they were not very large. Okay, it was not just inguinal lymphadenopathy. He also had hepatosplenomegaly, and this is a picture of a whole mount picture of his lymph node. And once again, you can see that it seems to be a diffuse proliferation. It is an infiltration because you still see remnant bits of the lymphoid tissue, and it has not gone out of the lymph node. It seems to be expanding or replacing the normal lymphoid character of this lymph node. Yeah, and this is what you see. Once again, you notice it's diffuse. You know that it is high grade because even at this far you can see mitotic figures. You see, it's very difficult to say, oh, I see some lymphocytes hanging around here and there. There are lymphocytes, but this is a lymph node. So obviously you are going to see lymphocytes over there. But you go to a higher power and you notice once again this very, very crinkly, cleaved, grooved nuclei. This is such a typical nucleus of tumor that is derived from histiocytes. But like I said, you have to be very careful to see how much cytoplasm there is because our commonly seen centrocytes have this kind of nucleus. We saw how some of these nuclei can look like the hallmark cells of ALCL, and of course lots of convoluted nuclei are seen not just in Langerhans cells but in a host of other histiocytic lesions. Okay, so histiocytes have this, or dendritic cells have these crinkly, coffee bean, convoluted, folded, cleaved nuclei, which may overlap with other kinds of cells as well. Okay, see this at hyper, and I think even a blind man can see how many mitoses there are in this lesion. Big vesicular nuclei, and notice the crinkly cytoplasm. I don't think you can miss that at all. So diffuse proliferation, indistinct cell borders, and all of that, which we of course you have to consider a hematolymphoid tumor and possibly histiocytic. Okay, so once again, there's no CD20, no CD3, no 5, and all of these markers 2, 7, 8 would be T cell markers. There's no CD10, 23, so it's not likely to be an FTC tumor. There's no 71, 61 because we do all these things when we think that it might be one of these odd myeloid extramedullary or even extramedullary myeloid neoplasms that might be showing you differentiation towards erythroid cells or towards megakaryocytes. Nothing that was positive. And yet here comes our LCA. Okay, it's an interesting state. You notice, of course, it's very strong in the lymphocytes in the background, but it is being expressed in those histiocytes. It's PAX8 negative, so it's obviously not a B cell lymphoma. It's not CD117 positive. So it's not got myeloid granulocytic differentiation. There's no CD34. Now CD68 and CD163. Okay, Do you think that these are positive? No, they're not, because the main cells of interest are negative. These are histiocytes, yes, that are in the lymph node. All lymph nodes contain a certain network of histiocytes, little cells, many things. So this CD868 and 163 are just there in the background. You see that the cells are definitely negative. I would read this as negative in the tumor for CD68 and CD163. All right, so could this be all right, we knew that 23 was negative, but do a 21, 23, is this an FTC? No, it is not. There's no CD1A, but just look at the S100 protein. Okay, so you've got S100 protein and you don't have CD1A, and this is not a phagocytic or a histiocyte. It's not a macrophage that is phagocytic. So this S100 protein is not representing an Rosai-Dorfman disease. So this is only S100 protein positive. Everything else except for LCA was negative. Okay, because S100 protein is positive, you have to be very certain that you are ruling out HMB45, melanase, OX10, do all of this to rule out a melanoma. And here, of course, comes the relevance of the question that was being asked. How do we know that it is not a melanoma? Yeah, it doesn't look like a melanoma, but spindle cell melanomas may have all kinds of things, except that this has got very histiocytic type markers. So I would not really consider melanoma in this particular case, but nonetheless, anything that is S100 protein positive and has no other marker, in this case there was LCA as well, and I don't expect to find that in a melanoma. You must rule out a melanoma, and we did every single one of that, as well as with, ruled out a plasmacytoid dendritic cell neoplasm. No langerin, no lysozyme, no BRAF V600E. There was CD4, which again tells you that yes, this is a histiocytic neoplasm, albeit that it is expressing S100 protein alone. So with anyone maybe in the chat box like to say what this is likely to be, one, dendritic cell neoplasm, it is a dendritic cell neoplasm, it's a histiocytic neoplasm, it is not one that shows macrophage type thing, it is not either a fibroblastic or a follicular dendritic cell tumor. So which one will only show S100 protein? What's coming up in the chat box? I'm sure Babita will have an answer to this because she usually has. Any one of our 5 students will tell me this? Huh? There is also CD11C in this tumor. Anybody?
You're answering indeterminate.
No, it's not indeterminate. It is S100 protein strongly positive. So what is that one thing? This is NPM. That's all right. I mean, most people don't have it. It is nucleophosphamine protein positive, but it is this. No, it's an interdigitating dendritic cell sarcoma. Okay, and this was presented by Dr. Jay Mehta, who worked with me at EAHP 2016. It's an extremely rare tumor. If you remember that a little cartoon that I drew, there was the Langerhans cell thing, and then there was one of those in that little triangle at the bottom. Things were going, each one could go close to the other. S100 protein without CD1A and langerin is expressed in an interdigitating dendritic cell sarcoma. Okay, so these are very, very vicious tumors. The bone marrow in this case showed involvement. You can see it over here. You can see the same type of cells, except that they seem to be looking a little bit more clear, but they are here in the bone marrow. It shows you the same thing, S100 protein, which is expressed in this bone marrow. Both the nuclei and the cytoplasm in this case are showing it. As I told you, it is usually seen in stage 4. The liver is showing a tumor. This liver biopsy was also done in this particular case. You see the S100 protein in the liver biopsy, and this patient had disease in the small bowel as well. So this is a FTC. It's not an FTC tumor. Sorry, it's a tumor of. You have to rule out, it's an interdigitating dendritic cell tumor. You can call it a sarcoma. In this particular case, you have to rule out an NCH, you have to rule out an FTC, you have to rule out a spindle cell melanoma, and you do that by doing all of these various markers. And then, as I said, you can have LCA, you can have 43, you can have 68, and also CD4. Okay, so it's a very rare thing, and I thought maybe some of you would like to see this, and that's why I put it up. It's not indeterminate because it's very, very strongly expressing S100 protein and not just S100 protein here and there. Okay, so will somebody now tell me, it's just a question, interdigitating dendritic cells are most numerous in what? Any one of you can answer this. Follicles, the T-zone, the medullary cords, the skin, or the bone marrow?
T-zone.
Yes, Gorik?
T-zone.
T-zone, very good. Who said T-zone?
Ointrilla.
Sorry, who did that? Ointrilla.
Yes.
Yes, Ointrilla, very good. Yes, it is. T-zone is the right answer. That's where you get interdigitating dendritic cells that are most numerous. Okay. Now, all of you, I want every one of you to go and read this paper. Okay, this is a paper on dermatopathic lymphadenopathy. Now, this is a wonderful paper because what it does is it tells you how to distinguish interdigitating reticulum cell dendritic cell tumors from Langerhans cell histiocytosis that is involving a lymph node. Please, this is an extremely well written paper, and here, of course, you see I've just taken this from one of their illustrations in that particular paper. You see the strong S100 protein. You may also see some patchy CD1A, and then you may think, this is Langerhans cell histiocytosis in the lymph node. So you should notice a few things. Number one, this disease is not in the sinuses. Okay? It is in the T-zone. You see that the follicles are intact, and then you see this pale colored T-zone. Okay, and this is how it looks, and you see these IDCs. And anybody who wants to do this, and if you do have some immunohistochemistry in your lab, just take a lymph node that has got it doesn't have to be dermatopathic lymphadenopathy, but a reacting T-zone, any reacting T-zone, just look at it. You may not be able to do all of the markers, but certainly do the S100 protein. And if you do have a CD1A, do it. And you'll be surprised at how easy it is to mistake it for Langerhans cell histiocytosis. But langerin is never positive in the interdigitating dendritic cell tumor. Okay, so of course people don't have langerin, but Langerhans cell histiocytosis in the lymph node is always in the sinuses. It does not appear in the T-zone. Okay? So just remember this when you are looking at this. All right, now just to sort of divert your minds a bit. The M group histiocytosis, that's the histiocyte, consists of all except what? Anybody wants to take it? I should have written A, B, C, D, E, F, G, or whatever it is. But the M group histiocytosis consists of all except what? Anybody here? Ulrich? Divya? No? Are you there or I lost you? Have I lost you all?
No, ma'am, yeah, yeah.
You're there. Okay. Yeah, so can anybody tell me?
Indeterminate
Angela, you've
sarcoma.
answered a lot of questions.
Indeterminate sarcoma.
No. It is a follicular dendritic cell sarcoma. So
Mhm.
now, just refresh your memory. Okay? All of the histiocyte groups do not involve anything that is of mesenchymal derivation. They are all from this myeloid stem cell. Okay? So if you have M group histiocytosis, it will not include a follicular dendritic cell sarcoma. Do you get it? Yeah, I hope so. Nobody's saying yes or no, so I don't know. If
Yes,
you
ma'am.
get it. Yes. All right. Good. So now we've finished that. Let's now come to this male, 55 years old, who had headache and disturbances of vision. The CT scan of the brain showed multiple lesions in the cerebral cortex and brainstem. He also had lesions in the femur. He had lesions in the ilium, in the femur, in the orbit, and the lesion in the frontal lobe was biopsied. And there's no prizes for telling me what this diagnosis is. Now, who's going to take this, Swati? Come on, Swati, quickly.
Ma'am, I think she had to leave because of some reason. Swati is
Oh, I'm so sorry. Angela, then come on.
Ma'am, is this perivascular lymphocytes?
Yes, that's the most obvious thing, right? But do you think that that's the lesion?
Ma'am, surrounding it, there are lots of cells with eosinophilic cytoplasm
Excellent.
and eccentric nucleus.
All right. Some may be accepted, some are not. Yes. Okay.
But they're deeply eosinophilic and vesicular. And oh, ma'am, there are also
Only histiocytes.
foamy histiocytes. Yes.
Only
Yes.
histiocytes are there.
Yeah, so there are foamy histiocytes. Excellent. Just sheets of them. Yeah, intermingled with these lymphocytes. Yeah, and some of these histiocytes have more than one nucleus. Okay, but when you see these histiocytes with these kind of nuclei, what else should you look for? Or what should you think about? Here they are at higher power. What are the 2 or 3 things that you should think about?
Xanthogranuloma.
Xanthogranuloma. Excellent. Very good. Yes. Angela, xanthogranuloma. It's excellent. Really good. Then, what else? You want to know whether there's anything in the cytoplasm of these cells? What
Yes.
things would you like to think might be in the cytoplasm of the cells? Angela?
Ma'am,
Lydia, what would you like to help Angela and say what should be in the cytoplasm of the cells that you should look for?
ma'am, nuclear debris.
Nuclear debris, okay.
I'm sorry, I mean
Would you like to see it? Emperipolysis.
Emperipolysis.
And very consistent.
Yes, you should look for emperipolysis. You should look for bugs. You know what is bugs? What's bugs? Bugs are organisms, okay? That's a colloquial word for organisms. So you should think, when I'm looking, I should look for organisms, I should look for emperipolysis. Okay, do you see that? Do you see emperipolysis or anything in these, at least you don't see any bugs? And emperipolysis? No, I don't see
Not
emperipolysis.
really, ma'am.
No, there is no emperipolysis, okay? So, and you look at the nuclei. That's something that is very telling. These nuclei, if this was really Rosai-Dorfman disease and there was emperipolysis, the nuclei would be large with a single nucleolus. That's the characteristic of Rosai-Dorfman disease. We can see it in the next case, okay? So there you are. You also have multinucleated cells, but yes, foamy macrophages, which suggests there's a lot of fat, okay? And of course, maybe this is the brain also, and then, when the brain has got something in it, there's a lot of fat that is there. So we saw all this, but the important thing is it's not just the brain. There's multi-organ involvement, including skeletal involvement. So this is, you're absolutely right, Angela. This is not granulomatous, xanthomatous process. It is not an epithelial granulomatous process. Are there bugs? No, we didn't see any bugs. It's the histiocytosis of macrophage type, right? Could it be a storage disorder? Now that could have multi-organ involvement. Yes, it could. But now you know the age of this patient, right? Now, this age, you wouldn't get a storage disorder coming up at this age. And it's not likely to be Rosai-Dorfman disease because there is no emperipolysis.
Yes.
And then you do some histiocyte markers, and what do you see? CD68. Yes, it is there. All the granules are there in the cytoplasm of the cells. It's not just outside, like we saw in the last case that we were doing. Now look at the marrow. The marrow too shows these foamy histiocytes. Now, if this was a younger patient or a young adult, you would worry about Gaucher disease, wouldn't you? Yeah, because this is how Gaucher's might present. Or something. Yeah, lipopolysaccharidosis or something of this sort. See, this is what you see there is in the bone marrow. Look at those cells. Same sort of cells. They're CD68 positive. Okay. And this is classical Erdheim-Chester disease. Okay, and I don't want to go through all of this, but it's a non-Langerhans cell histiocytosis. Yet, in the histiocyte grouping, the histiocyte society grouping, it is put into the L group because of its association with the, yes, 600E mutation. Okay, so this is a very classical case, but you must look for bugs in this. When I say bugs, I'm talking about organisms, both by stains as well as by cultural and, if necessary, serology. Okay, so it is a dendritic cell disease, multi-organ involvement. I think they put it into the L group, as I've already said. Yes, it's not called RAF, it is BRAF. Okay, mutation. All right, good. So now let's go to the next case. I do realize that we're going late, but I think there are some of these fascinating cases. And if any of you, if you're tired, just let me know, and we can just stop this particular thing, because I'm just showing you cases. I'm not giving you too much theory. All right, this is a 40-year-old male, multiple bony lesions. Okay. Just like Erdheim-Chester disease, it had multiple bony lesions, except that this had only bony lesions. Okay, hemoglobin was 11 grams, which I think is a little low for a 40-year-old male, unless he was a thal carrier. Yeah, it makes sense. Can a male who has 11 gram hemoglobin be a thal carrier? Lydia, what is the normal hemoglobin of a male? Lydia, are you there?
14 to 16.
14 to 16. So if you see a hemoglobin of 11 grams in a male, what would you think of? Iron deficiency anemia, yes.
Anemia of chronic disease.
Anemia of chronic disease, excellent. It could be iron deficiency anemia. It could even be a thalassemia carrier, right? Yeah, because it could be many things. Anyway, but otherwise, except for a slight low hemoglobin. Everything else appeared to be normal. All right, and this is his bone lesion. Now, what did I show you? Lydia, yeah, you can take this, Lydia. Okay, the last case that I showed you was a bone marrow lesion. Yes, this is a bone lesion, Lydia. Lydia, tell me the difference between involvement of the bone marrow and involvement of a bone. Does it mean the same thing from the clinical point of view?
Oh, ma'am.
Yes, Lydia.
Both are different.
They're different, very good. But what difference does it make from the clinical point of view?
Bony lesions will have mass.
Effects in the bone, very good. So from the clinical point of view, which is worse? Bone lesions, say, let us take a case like a neuroblastoma, okay? When you have a neuroblastoma and your marrow is involved or your bones are involved, okay? Is it the same? It's not the same, right? All right. Both of them are stage 4. Isn't that right?
Yes, ma'am.
Yes. But if in neuroblastoma, you have something called a 4S. Do you know what that is? That is stage 4 special. And it is called stage 4 special because despite the fact that the patient has diffuse marrow involvement, the patient does not have bone mass lesions in the bone, okay, and a huge liver. These patients do very well, okay? They are NMIC amplified and they do extremely well. So in a neuroblastoma, for instance, it's very important when you get a bone, needle core biopsy of the bone and it is involved. You must ask yourself, is this a marrow or is this from a bone lesion? Is it targeted the marrow or is it targeted the bone? And in other cases, if the marrow is involved, yeah, like in a plasmacytoma, if somebody tells me, or in a plasma cell neoplasm, and I got bony tissue and in that there are plasma cells, okay? Don't you want to know whether this is marrow or this is a bone lesion? And what would be the difference, Lydia? Which is worse? Which would
Lesions would be worse. Light lesions in the bone would be worse.
No, if there were multiple, right? But if there was a single bone lesion, then it's a plasmacytoma, right? So we can't equate, and you were right, bone lesions with bone marrow. All right, come on, let's see. And here you can see very obviously that there is this marrow in this bone. Okay, so this is a bone. The intertrabecular space is showing something. So now you tell me, what are you seeing?
Plasmacytoid cells.
You can see plasma cells. There's no plasmacytoid cells.
Plasma cells.
There are plasma cells. Okay. And what else do you see?
Lymphocytes.
What else do you see? What are you seeing here? What are you seeing here?
Histiocytes.
Histiocytes. Well, you're seeing large cells. Yes. You're seeing. Let me see if I can find other cells. Now, who's this? Who is annotating?
Sorry, ma'am.
Who's that?
Ma'am, sorry.
No, that's all right. You can see these big cells, okay? They're huge nuclei and huge nucleoli over there. And then you see these cells. Okay, look at this one big cell with a huge amount of cytoplasm. And what do you see in the cytoplasm, Lydia? Inclusions? So what do you think they are?
Digitations.
No, they're not interdigited. In fact, these nuclei are round. They do not have, just like the nuclei in Erdheim-Chester disease were round, but Erdheim-Chester disease, the nuclei were small. These are huge nuclei with nucleoli. But what's in the cytoplasm of these cells? And when you look carefully, look at this big nucleus, and this is the cytoplasm of the cell. And what's in it? Huh? What do you think is in it? Look at this cell.
Lymphocytes.
There are lots of lymphocytes sitting in little vacuoles within the cytoplasm of the cell. Look at this big fat cell. There's the nucleus there, and look at all these lymphocytes sitting in the cytoplasm. So now, what do you think this is?
Emperipolysis.
Absolutely right. Okay, now you look carefully and you'll see. But what I wanted to show you is that these are phagocytic cells. Okay, some of them may even look phony to you. There are cells here that look a little bit phony, but the nucleus of these cells is large and has a nucleolus. That is so typical of Rosai-Dorfman disease. Okay, you can't confuse it with Erdheim-Chester disease, which has small nuclei, and I just showed you that in the previous case. Of course, there is emperipolysis over here. Do you see the emperipolysis now?
Yes.
Look at that. And look at this big nucleus. And in the background, there are tons and tons and tons of plasma cells. Now, that is also terribly typical of Rosai-Dorfman. Okay, so now you've got a good picture of what is emperipolysis. I hope you do. Okay, very good. So, let me get rid of this. Why can't I get rid of this? Okay, good. Now, some more emperipolysis, more, huge cells. So, this is all over there. It's very likely to be extranodal Rosai-Dorfman disease. And here is our S100. Have you seen how the S100 protein has outlined the cytoplasm of the cells? Do you see that? Yeah. Look, the cytoplasm of these cells are outlined because S100 protein in histiocytes can be both nuclear, and you see the nucleus. Yeah, you see the nucleus of these cells, and you can see the holes or the what do you call it? They're not phagosomes, but they are intact vacuoles in which these lymphocytes are placed. And now you see that how beautifully it is brought out by the S100 protein. So this is definitely emperipolysis. There are such large, look the size of these histiocytes, because it's all, and it's stuffed with these lymphocytes. And I just wanted to show you, see here you can actually see nucleus that is taken up the stain, which is S100 protein, very dense nucleus, and you see the size of this nucleus. So please remember, Rosai-Dorfman disease has got big nuclei with nucleoli, and both the cytoplasm and the nucleus will be stained. And this is such a beautiful stain because the emperipolysis is brought out beautifully in the S100 protein. Do you agree? Yeah, which you sometimes are not able to see very well in that. Now this you can do a kappa or lambda light chain to see whether there is these plasma cells are monotypic.
Monoclonal.
Yes, but in most cases they are polyclonal. Occasionally they are show you a lambda like restriction, but I don't think it makes any difference. In this case, it was just polytypic. Okay, so this is Rosai-Dorfman disease in bone. Excellent. So now, this is a 74-year-old, multiple nodules and plaques. Now it's your turn again, Gorik, over the upper trunk. So this is a skin disease.
Lesions.
The biopsy of a skin lesion was done. Come on, now, Gauric.
Okay.
We've done two skin lesions before. Now this is the third one. Now you
Yes, ma'am.
should be very, very good at describing skin lesions. Come on.
Ma'am, the lesion. Hello. Yes.
Come on,
Ma'am,
Gauric, jaldi. Everybody wants
yes, ma'am.
to guess and go and have dinner.
Ma'am, the lesion shows sheets. Yeah, it shows sheets of histiocytes looking cells.
Now listen, now you can't see, I can't see foamy histiocytes. Nobody can see foamy histiocytes. Okay, this bar is too low for you to see foamy histiocytes. No, so
Yes,
just
ma'am.
tell me what you see. And I told you, no, you have to ask yourself some questions. Is there any
Yes, ma'am.
normal tissue seen? Yeah, this is supposed to be a skin lesion. Is there any normal tissue over here? And the answer is yes. There is a normal epidermis. Yes.
Yes, ma'am.
Yes. Okay. Is there any abnormality seen? Second question. Is there?
Ma'am, not visible at this magnification.
An abnormality is not visible. Then what the hell is all this? This is normal skin, is it?
No, ma'am.
No. Is that normal skin?
No, ma'am.
All this is normal skin. But this thing is over there. Certainly not. So there is an abnormality. Yes or no?
Yes, ma'am.
Oh, very good. So third question: what is the relationship of the normal to the abnormal?
Ma'am, it is very close to the epidermis.
Yes, but
It's not infiltrating into it.
because you can see a Grange zone. Can you see or not? There is this pink line that is at the dermoepidermal junction. Can you see or not?
Yes, ma'am.
Which is not infiltrated by this tumor. Now, do you understand what is a Grange zone? Yes. Angela had answered that. Was it Angela? Did you answer that Grange zone?
Yes, ma'am.
Yeah. So now you can see a Grange zone. Okay, we'll see it at higher power, but this is a Grange zone. So you see a band-like infiltrate. Okay, that is seen in the upper dermis. Okay, there is a clear Grange zone, and then you also see little peri-adnexal and perivascular foci of the same kind of infiltrate. Can you see it or not? Here is an infiltrate around this hair follicle. You can see an infiltrate here, which is possibly around a blood vessel, etc. There's another hair follicle that has been infiltrated. Okay, here again, you see how beautiful your Grange zone is here, Angela?
Yes,
There's nothing there. There's a clear Grange zone, and this is important. And when you have your talks in dermatology, it will be emphasized. Okay, that you see that Grange zone. Now you see your wonderful Grange zone or not?
Yes, ma'am.
Yes, ma'am.
Now come on, Gauric, describe this. Because we said that you should ask, is there any normal tissue? Is there any abnormal tissue? Then the third thing is, what is the relationship to the normal? And we said that it was in the dermis and it was around all these little hair follicles, the abnormality, and there was a Grange zone. Now, what is the fourth thing? What is the pattern of this abnormality?
Yes.
Now, you tell me what is the pattern of this abnormality, Gauric? It is so typical. You
Ma'am,
could see it at low power, it was sheets. Now, what is this pattern?
Story form.
No, you think it's story form? We never use this word story form unless you have a spindle cell tumor, no? You think that this is a spindle cell tumor?
No, ma'am. Not spindle
No,
cells.
it's not a spindle cell tumor.
World.
Word
Slightly
pattern.
world. Slightly world.
Slightly whorled, okay, very good. But what else do you notice? Don't you see, even if it is whorled, have you seen that they are all one next to the other in cords? No, there is a cord-like arrangement to this tumor. They're marching one, behind the other. Now see where my cursor is. Yes, there's short or long cords. Am I imagining it, or can you see it as well? Oh, they're all in cords. Look at that cord that is seen here. You see other cords. Anybody in the chat box is not seeing cords and wants to challenge me? There are cords. You can see that. You can even see it in high power. You see these things all going in cords, and the cords may be bending. The cords may, be in a whorled fashion. I agree that there are areas where there are no cords, but you should be able to appreciate the cords. Now, Gauric, when you come to high power, the cords will obviously not be as visible as you see when you saw it at low power. But can you describe these nuclei or describe the cells?
Ma'am, the cells are somewhat eosinophilic in nature. They have like a eosinophilic cytoplasm with
Yes.
a prominent nucleus,
Yes, very good.
and also.
Yeah, but you just said prominent nucleolus. Just immediately after the cytoplasm, it became the nucleolus.
Yes, ma'am.
What is the nucleoplasm like? I never heard anything about the nucleoplasm, Gauric.
Yes, ma'am.
What is it like?
Ma'am, it appears slightly eosinophilic.
The nucleoplasm looks eosinophilic. Huh? Do you know what is eosinophilic, Gauric?
Yes, ma'am.
Eosin is what color?
Pink.
Pink. So now you're telling me the nucleus or the
No.
nucleoplasm is pink.
No, it is
No,
not.
no, no.
It is.
So,
It's prominently basophilic and
it's not deeply basophilic. In fact, it is pale. Look at it. It's a pale basophilia. These nuclei are pale. Yes, they have a nucleolus and it looks